The one that I'm kind of leaning towards is a triathlete with chronic anterior hip and abdominal pain that we treated with TL junction manipulation, resolved a UFER and some dry needling, and then some pelvic PNF patterning and some motor control exercises.
Did you play with the running pattern? Can you hear me, Chris?
Did you say that again?
You play with this running pattern.
I missed you. We did look at it. She was, what I saw was that she didn't have good pelvic posterior depression at push-off. And even through the end part of swing, she really just didn't get a good anterior elevation. I was mostly looking at her pelvis at a more central versus a more distal influence with a running pattern. Okay,
cool. Well, we'll also go into two here a little bit today. I was going to go over some of the slides in Module 5, and I'll send them out when I'm done. I was just putting them together. And it's kind of also what we'll play with a little bit. It'll be new to some of the fellows, too, is looking at, I'm looking at Diane Lee's model of sacral locking and, it's basically the dynamic stability of that. And that's probably what we'll do in the next session.
Okay.
But I'll set it up a little bit today. With runners, too, with that, if it's anterior hip pain, one of the things I look at is just cadence and speed. Depending on the age of the individual, oftentimes the anterior breaks down because they linger that foot on the ground too long, which is common in triathletes because they muddle, that they tend to beat up their anterior hip. Their turnover rate tends to be a little bit slower, and they tend not to flex the knee as much as they run because, they just came off a bike. So that's one of the other things, too,
okay.
Is the anterior hip pain. I also make sure I clean up in them, or else they might be back in 6 months as they start to muddle more.
Okay.
So that'd be a good one.
Did you say muddle?
They muddle.
Did you say muddle?
Yeah, you ever see a triathlete run?
Yeah.
Yeah, they shuffle. They do the triathlete shuffle.
Okay.
They're all stiff coming off the bike. They kind of muddle along there. Slang term. Yeah, mostly used in the East.
Okay.
But now that'll be a good one to look at. Maybe we can bring it into this.
Okay.
Leslie, how are you doing?
Well, if you get a chance,
Send it over. Wait. No, I'm sorry. Chris, what were you going to say?
I was going to say, if you have a chance, I sent about 3 other ideas, so I was curious if you thought maybe one of the other ones was a better way to go. So after this, if you look at it.
The easiest one is the best. The one you think is the easiest.
Okay. Okay.
Good. Let me just double check, make sure it's not.
I see Leslie's on here.
All right. And also kind of get a standing view as well. I guess the easiest thing to do is, does anyone have any questions? You can hang out, Zach, if you want to. Does anybody have any questions for me or for anyone else? Eric Skarda is going to probably join us in a bit as well. No questions.
Marissa. Hey, you mean questions on specific techniques?
You can ask me anything. You have modules 1 through 4 under your belt. I'll try and field any question I can. If I don't know an answer, I'm happy to make one up.
Well, Chris Gray would say I need work on my OA mobility.
Yours personally, or?
No, on my technique.
On your technique?
On my technique, yes. Not mine personally, but
okay.
That could be true.
Cool. If you have a little time, maybe I'll do that on the back end. There's some other people in here at Module 5, and I figured I'll do some early stuff there. And if you want some OA technique, I can give you some OA technique. Unless
okay, yeah.
Unless you'd like me to do it now, because some of the people here won't have had that yet.
That's fine.
You're looking to mobilize or manipulate? Actually, it
both.
doesn't matter.
Well, both. I know. I'm good with the long axis manip, but okay. I was more thinking the seated mobs.
The seated mobs?
Seated mobs, yeah. During our last one-on-one mentoring with Chris, he wanted to review that with me, and then we never got around to it.
Okay, we can do that. It's it's funny. I don't use the seated mobs as much, but it's one of the things nice thing to do because it's really just applied biomechanics. if I talk you through seated mob, if you think about craniovertebral flexion will be the most common one that you'll do. And that's going to be basically just craniovertebral flexion. And you can block C1 and mobilize the occiput on C1 or C1 on C2.
Yeah.
We have a side.
Are you just doing the manip more, Dave?
This way.
Are you doing the manip more? Are you just doing the long axis manip more for OA then?
Yeah, for OA, and once you set it up, very few you'll probably need to manip as you get better at it. By the time you load and lock the joint, then it goes pretty quickly for an OA joint. AA joint may take a little bit more force, but the OA joint, once you get a clean traction set up, very rarely do I need to manipulate it. I just do it every now and then to prove to myself that I can, without stroking somebody out. Seated manip, and again, if you guys are in Module 5, you may have had a little bit of this in Module 2, but they may never have gotten into it until you get to 6. What I'm doing here is basically mobilizing the head on C1. And what I'm going to do is since you're in the camera, I'm going to do his left side. Can you see it, or is it out of view? It's out of view.
No, you're good.
You're good.
It's a head cradle, and I always start fairly soft. So I'll just kind of bring my hand up here, get my knee up to get me a little taller. A chair would be nice. Think about, again, my pad of my index finger. If I want to take the occiput back on C1, what I really want to do with my index pad is get up in here and block C1. And now what I can do is I can use craniovertebral. I'm going to exaggerate the motion, use craniovertebral flexion, and I can either use like a rotation and side bending. So what I'm doing is I'm either driving C1 anteriorly with my left hand, or I'm taking the occiput back over a fixed C1. So first technique is fixed C1 with my left hand, and I take the occiput back. I'll flex him and side bend him toward me with a slight rotation to his left. And I can now, again, I got craniovertebral flexion of the left joint with that position. Again, or fixed hand, and I can rock the head into that motion. Does that make sense?
Yes, it does.
Yeah.
Okay. Matt, is that how you were taught it?
Yeah, so it's all like that, and then I was shown, how to mobilize in supine as well.
Yeah, supine ones I use more just because we have people in supine more, and it feels like you're putting somebody to death.
Yeah.
Like Justin's easy, he knows what I'm going to do to him. But the patient doesn't know what I'm going to do to him. They have cervical pain. Me putting him in the headlock position to start off with, it's an awkward way to start a relationship.
Build trust quickly.
Yeah. Hey, so for those of you who just joined us, we were asked by some of the fellows about occiput, basically the head on C1 mobilization, and that's what we were just demonstrating. And the reason why I use it is if you think about the forward head position, or where most people will be locked, is you're being craniovertebral flexion. Good. So the technique we were just showing was one basically, if you think about the forward head position. So I don't bother doing a chin tuck or any neck retraining exercise until I basically looked at occiput on C1. Or C1, or really C1 on C2, because if I'm stuck in a bit of craniovertebral flexion in this position, and I can't reset this way, then the chin tuck exercise is going to be naturally inhibited, and they're not going to be able to maintain it. So what I want to make sure that, again, is checking occiput on C1. And any cervical patient is one of the early things I check, because if I have any restriction up above C2, C3, kind of keeping them here, then any of your kind of exercise you're training, it's basically not going to work, in my opinion. You can needle it as well and see if those muscles then relax. If it's a muscular issue, it may help. But if the joint is restricted up in the upper cervical spine, and the common one I also see is C2 stuck extended on C3 in the forward head position. It's a common joint to get arthritic and stuck. And I try and clear those first, and that clears a lot of it out. And then I can go into some of the cervical retraining and repositioning and posture exercises to reset it. So I think they go hand in hand nicely, especially if you look at that pattern of I want to clear the joint. I can use needling basically to decrease muscle tone, or basically just managing and modulating pain in that region, and then retraining exercises. So I do you think of that as a nice little package as far as occiput on C1? Does that make sense?
Yes.
Or is everyone lost because they're coming in and I'm discussing cervical spine? Hey, here's Eric. Hey, Eric, how you doing? Can you hear me, Eric? Yep, Eric's in there somewhere.
Just jumped in.
Hey, Eric, how you doing?
Good. What's going on?
Good. Now, just one of the fellows just asked me about mobilization of occiput on C1, so we just went over that briefly.
Okay.
Now we're just kind of opening up the questions. So does anybody have any questions for Eric? Anything? No questions? Well,
You guys tried to pull this on the last module too, and that didn't work out.
yeah, crickets and tumbleweeds. I'm gonna make it easy on you. Here's what I'm gonna do, because I figured I'd either answer an hour of questions or answer no questions.
Okay. Can you hear me? Questions was regarding like hand placements for rotexion and latexion. You know, when we originally went through it, I think Scott used the knuckle technique. I think that's what he said he referenced, but I just kind of wanted to discuss, like, you know, hand placement for those two techniques. And then also just to kind of talk through, like, how do you go through finding the actual level where you would, I mean, I know it's not like a general, like, not working up a set with this, but how do you figure out where exactly you're going to actually put your hands and actually do the mobilization and manipulation?
You're talking to the thoracic spine?
Yes.
Yeah. So localizing the level of the lesion is a relatively simple thing. The way that I will tend to do it is there's a very distinct muscular hypertonicity that occurs as a result of the rotatories crossing the facet joints. Okay, so that was the muscular hypertonicity that we were finding just by running our fingers down the paravertebral gutter when we were in class last month. I guess it was 2 months ago now, but no, it was last month, wasn't it? So basically, when you find that bilateral hypertonicity, that'll tell you that there's a dysfunction at that level. It doesn't tell you what the dysfunction is. It just tells you that there is one. So essentially, if you're noticing that a patient has a loss of, say, right latexion, and you can isolate that there is a hypertonicity at a particular level, that gives you an idea that that may be the level involved. Now, as far as hand placement goes, the rotatories are indicative of the bottom half of the movement segment. So if we're looking at a T6,
okay.
The best way to localize the level of the lesion when you're looking at anything in the thoracic spine is to look for the level of hypertonus of the rotatories. Okay, so those are those small intersegmental muscles running from the base of the spinous process of the superior level to the transverse process of the inferior level. Okay, so they run horizontally across the level. We lose me again?
No, you're good.
Okay. So the easiest way to find those levels of hypertonicity is just to run your fingers down the paravertebral gutter. Now you could do kind of jam the fingertips into individual layers, but I tend to do it with both fingers so that I can feel it bilaterally. It has to be bilateral for it to be significant. Okay, so once you find that, then you know that there's some sort of dysfunction at that level. That doesn't tell you what the dysfunction is, it just tells you that there is one that needs investigation. So the way that I will typically do it, if I've got a patient with their back exposed so I can see their skin, work my way down the thoracic spine, and I'll just find the levels of hypertonicity, and I'll just put a scratch mark, just a little hyperemia scratch mark right across that level. And then if I find 2, 3, 4, something like that, those are the levels that I have to investigate. So if I have a patient that comes in with a notable loss of right latexion, and I have two levels of hypertonicity, those are the only 2 levels that I have to do my PIVMs and PAVMs at. Okay, so as far as localizing the level of the lesion, that's the easy way to do it. Rotexion and latexion lesions, well, because they are an intersegmental problem, they don't just involve the facet joints, they involve the whole vertebra along with the ribs. Those things will tend to have very similar, like a U-joint lesion in the neck. They will not be affected by flexion or extension. So if you do positional testing in neutral, the patient's upright and neutral, and you get your thumbs into the articular pillars, you'll tend to notice a deviation. One side will be deeper than the other. You move them into flexion, that deviation should stay the same. You move them back into extension, and again, the deviation should remain the same. If the lesion is a posterior element problem, like a facet joint lesion, those things will change with flexion or extension. Does that make sense? Yes, I'm seeing some nodding in some areas. Okay, so localizing the level of the lesion, that's the simple way to do it. Feel for the hypertonicity, okay, scratch mark there, and then do positional testing to check for changes in flexion or extension. That should tell you that you have either a rotexion or a latexion lesion, and then you're just matching that up with whatever the motion loss was during your active movement and overpressure tests.
And Eric, you're just doing straight.
So is this recording, right?
Yes.
Yeah. Okay, good. Because it in and out again as soon as you started with finding a Rotatories, it just went right out. So I'll just look back at the recording.
Okay. As far as hand placement goes, the way that I do it, I will tend to use both my knuckle and my thenar eminence, and they go right on the line of hypertonicity because that delineates the lower half of the segment that's involved. Okay? And then depending on if I'm going to, okay, good. Depending on if I'm doing a positional manipulation where I'm going to bias them into a latexion, my thrust goes straight down toward the table. If I'm doing a linear manipulation where I'm trying to improve the shift that's occurred, right? So if I've lost right latexion, the translation that I've lost is left translation, right? So if I'm doing that, my handhold stays the same, my thrust vector just changes to going towards a left shift. Okay, but I have to be on the bottom half of the segment in that case so that I don't block the shift of the segment I'm trying to correct. So if I'm looking at a loss of T6 latexion, my hand has to be on the articular pillars of T7. That makes sense?
Eric, do you see the traction for this? Usually with some of these rotary techniques where it's a translational loss in that segment, sometimes my first go-to would be a seated traction technique on that segment. Do you usually go there, or do you prefer the supine translatory?
It kind of depends on the patient's preference. I'll do those seated traction techniques a ton.
Yeah.
The difficulty is with a translational lesion, a rotexion latexion lesion like that, it doesn't always correct the shift. So depending on where it is in the spine, if I'm looking at something above T6, I do like the seated traction technique to correct those. But if I get below T6, having to do a drop technique for a translational shift, I don't think it's as effective. And those are usually the ones where I'll bias them before going in and doing it and do it in supine. But I do a lot of supine traction techniques as well, which I think we went over during the Module 4 course, just the basically fixate the bottom level, and then instead of thrusting straight down toward the table, we thrust kind of up vertically through the spine, almost toward the shoulders in order to still produce that traction technique or that traction moment going through the target segment. So it kind of depends on the situation. Below T6, I'm not usually going to do that seated traction. Above T6, it works just fine. But I'm always a little wary of how well it'll actually correct the linear shifts there from side to side.
Yeah. It's funny. I notice a lot of people do it. I picked it up on the fly, probably from Gail and others, is that, even when they do the seated traction technique, generally what you're going to find is you pick these people up, and Scott does it too, but Scott does. I tend to kind of fuss and fiddle with them a little bit and take them left and right. So if they're translated to the right, many times as I do a seated traction as I pull up, basically I'll create a left translation. And many times what you'll find is this joint will clunk just with the seated setup. So it's always kind of trying to find what is that worst end feel. So if I have that person who's translated to the right at C6, and I go to do that lift technique on them and pull, I generally will kind of pull up and I'll bias a little bit and pull a little bit to my left through that segment. And many times that's where I'll correct that translation. And that translation
that can work just fine. Absolutely.
Yeah, that's what I see other people do. It's kind of, as you do it a little bit, you kind of fuss and fiddle with the end feel. And it's probably what Eric does a bit in positioning. It sounds like when he's doing supine, he's getting him supine. And he kind of knows the position. If they're shifted to the, let's say to the left, he knows he's going to bias it to the right in his setup. And it's a good thing to think about because you manipulate a lot less when you start trying to practice clean setups, which is kind of fun.
Yeah, I think for me, the reason I usually will tend to kind of gravitate toward those supine techniques is that the kinesthesia that I have with my right hand underneath a patient has gotten to the point now after doing a few 100,000 thoracic techniques.
Yeah,
has gotten pretty good that I can get them into a position where I'm literally right at the barrier, and it doesn't take much force. Sometimes all it takes is them breathing out and me just leaning over them for it to cavitate and give. And that kind of takes away a lot of the apprehension that the patients will have, because you'll get those patients in occasionally as they're kind of wrapped up like this, that they'll tighten up through the shoulders and you're just going to bounce right off of their shoulder girdle and you're never even going to get down to the thoracic cage. So however whatever one you feel like you're having the best success with, you'll find that you end up having a go-to technique. I mean, for me, this is the supine one tends to be the go-to technique for me. Dave tends to do a lot more of the seated traction, and that, they both work.
Yeah.
The hard parts are the ones where you have patients where your preferred technique is not comfortable for them. For instance, my wife has some thoracic issues like most people do, and she can't tolerate the supine techniques. So just because the hand behind the back is too much for her, she's got really flexible shoulders. So trying to get down to the barrier through her shoulders hurts her shoulder joints, or just hurts through the glenohumeral joints. So we have to do seated or standing traction techniques on her because she can't handle it the other way. In other cases, you may find that patients have a hard time kind of getting down to the barrier when they're in seated. I think I told you guys this story about patients snapping their head back when you go to manipulate them in those seated techniques, and they could schnocker you right in the nose, and nobody wants that. So it all depends on what's best to get the patient relaxed, where you can get the best end feel, and where you can bias the direction that you need to correct the lesion. So depending on what that is, you might have to play around with it. I mean, I've done techniques on patients here in the clinic where I'll try and do the supine technique. I get nothing out of it. It just doesn't work, and I have to sit them up and try another one. There's nothing wrong with that. That happens all the time.
Yeah.
Hey, Dave, can we talk about some biases in sitting? Like hand positions or block?
For the seated techniques in the thoracic spine?
Yes.
Okay. It's really nothing fancy. If you think about, we have a translation. Let me see if I can, let's swing to the side this way. Is the camera angle okay? Actually, swing. Yeah, I'll mimic it here. It's really going to be about, once I get him here, let's say he's translated. We'll go with a left translation. He's translated this way. So as Eric said, the one thing I always do is set up to the side. And I always tell them to lay their shoulder here. So in his case, if he's translated to the left, I'm going to lay his shoulder on my left side. That keeps my teeth in my mouth when I finish this technique. And as I pick him up, I'm going to exaggerate. I can bring him a little bit to the right. And I'll bias him to the right. Because I know he's translated to the left. Now, I have a good chance of success if I get the right pull on him, if I pull him up and to the left. But many times I can unload, laterally shift till I feel I get up to the segment, and then I can either do my pull technique or a drop. Now, I didn't use a towel here. The towel would add an extra layer. On this one, if I'm going to do above technique, towel is going to be the level below. So as I apply my traction, I'm going to pull him up, and I'm going to pull and shift his body weight to the right this way to create that translation. If he's got a left translation with a right thoracic, with a right rotation. So just remember, the left translation will match a right rotation. Is that correct? The translation is always opposite the rotation. So be with towel, I pick up, and then I would kind of shift my weight here. Sometimes I even add in a side bending. Generally where I'll get him is with a side bend or rotation. I can take him left or right, and I can even just pull and rotate that direction to see if I can't free him up. Now, it can go either way. It's with the body rotation, but the term Jim always used, which always stuck with me, was like fussing and fiddling. We tend to kind of fuss and fiddle within that position to see if I can just free it up first. And then once I do, I can take it at translatory barrier. Like I may take him from left to right and then apply my quick traction if I need it. But you'll find oftentimes 50% of the time or more, I don't need to actually even apply the manipulation. Just kind of winding them up in that position is enough to get the joint to go.
Yeah, that's what Gail calls just finding the barrier.
Yeah.
It's just about taking up whatever kind of degrees of freedom you need in order to essentially tighten the system around the joint that you need to manipulate. So we were trying to think of one that we did in the periphery. So if we think of our abducted ulna technique, where we're here, and essentially all we're trying to do is mess with pronation, supination, amount of extension, the amount of translation, the rotation of the shoulder girdle, whatever you need to do, any type of added traction or compression that you want to put through the segment in order to tighten it. And basically you're just looking for that crisp end feel. So yeah, I mean, the term fussing and fiddling is not exactly scientific, but it's exactly what you're doing. You're just playing with this thing until you find that angle, that vector of force that you need to put, along with the different technique, the different components of traction, compression, side bending, rotation, depending on the joint that you're doing. For the elbow, it would be more pronation, supination, flexion, extension, that sort of thing. It just takes practice. It's all you want to do is just spend time finding those barriers. The fortunate thing is that most patients that come into the clinic will have many of them to do. Especially spinal patients, you'll be able to find barriers on patients, even if you're not particularly treating a region. When I was doing my fellowship work, anytime a lumbar patient came into my clinic, I examined their foot because I wanted to know how the reactivity of the ground reaction forces were going to affect the lumbar area. It was just a way of me getting more time in on treating the foot because it was something that I felt I needed the extra time on. So similarly, if you have somebody that comes in with knee problems and you're suspicious that they have some sort of descending influence, you can go up and examine lumbar spine, you can go up and examine the thoracic spine and just tell them, hey, you know what, I think there might be something to this. We're going to check it out and see if there's something going on here. And, whether you want to try and actually relate it to the problem they're having, or if you're going to say, you know what, this is probably just an artifact, I'm not going to worry about it, I'm not going to add another thing into the process here, that's fine, because all you really need to do is just spend the time fiddling with the segments. So you can find ways to practice this stuff all day long with your normal patient load. But that's all it is, just repetition.
Yeah, that's kind of the general rule is that if the patient knows me and they've come to me before, then I can go from a knee to a thoracic spine first session because they know me, they know my style, they're probably here to see me because of my style. If it's a new patient who's been referred by somebody who hasn't seen me, then in that first visit, I discuss basically the center of mass, like where their body weight is, and that if their thoracic spine is anteriorly or leaning forward because of a joint or something's off, it's going to load their knee or their hip, and I have them sway back and forth. And I set it up in the first session, and I tell them that we're going to further evaluate that in the second session. So I may go from a knee or a hip to a thoracic spine, But depending on the individual, I'll kind of set that up so that the second time that expectation is, oh, you were going to look at my thoracic spine because of, you know, the way I may be standing over my knee. So just know that sometimes know your patient and then know, okay, where do I want to go with this and how do I frame it so that I can get to that end point? Because some people will be really put off by it if they don't know you. So just kind of set it up that way. It tends to flow pretty good, in my recommendation. And Eric, I mean, how do you do it? Similarly?
Sorry, my son was walking in, so I missed part of that.
No problem. How do you set it up when you're looking at a thoracic spine? Do you do it the same way? If somebody's with you the first time, you can kind of, or you have to frame it a bit.
Yeah, I mean, it kind of depends on what I think is really driving the problem. You know, unfortunately, you start to see these patients that come in for knee issues, and you look at the knee and you start thinking, yeah, they've got, well, first of all, the problem is bilateral, came on at the same time, no particular trauma. So you have to suspect that there's more of a central problem to this. So you have to go up and examine the lumbar region just because you have to suspect some sort of, you know, old disc lesion, some sort of facilitation, some sort of instability, something like that. So trying to convince them that, hey, you know, I know you're coming in for your knees and you're having some issues with that, but I think the problem is stemming from here, and here's why. If you can give them a good reason and you can be crisp in your delivery on how you're viewing that sort of thing, because the problem with that is then you have to figure out what caused the lumbar problem to begin with. And that may mean you have to go up to the thoracic area. It may mean you have to treat the hip. It may mean you have to go back down and treat the foot. Who the hell knows, right? So as far as, you know, that first initial patient goes, that first visit, my first order of business is diagnosing where the problem comes from. So if that means I have to kind of spread out and move to different body regions, then I'll do it. But you can usually tell the patients that are having a tough time getting their head around where these things are coming from. So in order to do that, sometimes you have to placate them and say, okay, well, we're going to do these things for your knee. But I also think that there's an issue here that's contributing to it. So we're going to go up and address a little bit of that. But you don't want to focus all your time in a remote region. You know, patients coming in for their knee, they want you to look at their knee, right? You don't want to spend 40 minutes playing around with their back because they're just going to look at you like you're nuts. I think I told you guys about one of the most common reasons that you get kind of medial knee pain is coronary ligament irritation, right? And one of the most common reasons that you get coronary ligament irritation is a loss of hallux extension. So if somebody comes in saying that their knee's bothering them when they're running, and the thing that I tell them that I'm going to do is I'm going to treat their big toe, they're going to look at you like you're nuts, right? So you still have to do something in order to kind of build that confidence and build that trust before you go in and you start saying like, look, this is where we have to focus all of our efforts. I don't know. Does that answer your question, Dave?
Yep.
Good.
Okay. We had a couple questions put up on the Zoom chat. One was, the first one's, can we elaborate on the significance of bilateral hypertonicity?
Yeah. So when we're looking at the thoracic segments are very singularly segmental. They don't have a limb in which to refer to, so there's not a lot of overlap between one level and the next when we're looking at myotomal and dermatomal distributions. The rotatories, because they only cross that one level, they're very singularly segmental to that one spot. The only reason that we have to worry about it being bilateral is because of the reflex arc. So it'll spin through the thoracic reflex arc and affect both sides. So if you have it just unilaterally, as far as that hypertonicity goes, it probably only means that there was swelling there at one point across that facet joint. And you may have a capsular issue with that restriction, but it's because of there being so many joints in just one segment of the thoracic spine, and then combined with the 12 wrinkles of the thoracic spine, it's not going to be real significant, real substantial. So looking at the bilateral hypertonicity, that's when you know that there is some sort of segmental problem in that level. Now, that could be a facet lesion. It could be a unilateral facet lesion. It could be a unilateral rib lesion. It could be a facet restriction that's causing an irritation of one of the adjacent rib. It could be a segmental lesion like a transverse shift. It could be a segmental lesion like an anterior shift. It could be an instability. We don't know what it is. All it's telling us is that if we're dealing with thoracic symptoms, we have to examine that level for what's going on there.
Yeah, I mean, there could be you could have hinging at that level where you're getting extra irritation. It could be that it's, oftentimes you can think of a failed load transfer can do that, where let's say I'm squatting and moving weight, and okay, is that a hinging point where now all of a sudden as I try to transfer load from my legs to my shoulders, my upper body, am I getting a hinge point or a fail point there? You can see any variation there. So I can have hypertonicity there because that's where I'm getting the added stress. I'm not transferring it straight from legs to shoulder girdle. That segment is failing. The rotated segment there could be it as well. I could have, you'll get more into this in module 6 and 7. So for the fellows, okay, I could have basically a pelvic torsion with unlocking a nominate can drive muscular tone upward, and that can create a rotated segment. We'll do that in one of these Zoom labs. We'll add it in the future. We'll take a look at that segment. That can give us that. Sometimes it's unilateral, sometimes it's bilateral. But a good way to think about it too is that you can have this thoracic shift that's occurring where, okay, let's say if I'm shifted down to my pelvis, now my thoracic spine tries to make a correction. So my right hip goes anterior, my shoulder girdle is going to swing. I'm going to swing around somewhere in my thoracic spine and create a right rotation to counteract my pelvic left rotation. Now we could see a hypertonicity in that segment there, because here what I have the ribs doing is, as I go this way, I'm going to get this rotation of my ribs. Both ribs are going to go. It's a cool way to think about it is the ribs with their rotations will follow what the innominate would do. When my innominate goes anterior in this way, it's the same rotation as the ribs. If my ribs are rotating to the left, it's kind of like the same as if I rotate my pelvis to the left, my left innominate goes anterior, and my right innominate goes posterior. Ribs do the same thing. If I rotate my thoracic spine to the right, I'm going to have an anterior kind of rotation of my relative left rib. My right rib is going to go posterior, and I'm going to get a translation to the left. So if I'm bound to that segment as a correction for something lower, I could have hypertonicity there from irritation, and it could present there as well. Does that seem reasonable to you, Eric?
Oh yeah, I mean, and one of the most common ones that you'll see is in a like an endurance athlete, or even a more of a dynamic, like a sprint athlete, like a soccer player or something like that, is you'll see, and we talked about this a ton during the 4th module when we were going over and kind of reviewing the TL junction stuff. If you see somebody that has a problem transmitting load through the TL junction and up into the rib cage, what you'll see patients they'll come in with mid-thoracic pain. It'll be like right between their shoulder blades. And when you watch them walk, if you dress them down, you get them with where you can actually see the skin, you'll see that all of their rotation of their trunk occurs through the upper rib cage, usually somewhere between T4 and T6. And you'll watch them move, and the lower half of them the pelvis just stays straight. Nothing moves. And all of the rotation occurs way up the top. The pain producer is going to be the one that's hypermobilized, right? It's going to be the one between T4 and T6. That's the victim in this problem, right? But the culprit, the thing that we are actually going to have to treat, the way that we fix them, is down at the TL junction. We fix that, suddenly they're rotating through the lower rib cage where they're supposed to. We take all that pressure off of the mid-thoracic. So, I mean, and this is the same with any type of orthopedic condition that comes into our office. It's just, what is hurting them? What's the pain producer? Is it a ligament around T4, T6? Is it the rib? Is it the facet joint? Is the whole segment unstable? And why did it get that way? That's our diagnosis versus our etiology, correct? So we're looking at diagnosis is instability at T4, right? Translational instability, lateral instability at T4. The etiology is due to hypomobility at T10, T12, etc. Does that make sense?
Okay.
Yes. Okay, good.
Someone also asked, can we demonstrate hand position to bias upper or mid active range of motion with OP? I'm freezing on that one to confirm latexion or rotexion. So basically, I don't know is what is the hand position you use to confirm latexion or rotexion
In the thorax. So because it's a ring issue, you have to fixate the ribs, right? So what you're going to want to have is you're going to have a wide grip and try and get your fingers as wide as you can onto the rib tubercles. And then you're going to squeeze those things as tight as you can get them, right? And then I'm going to come around from the opposite side and I'm going to pull the shoulder girdle above that level, or I'm going to push the shoulder girdle above that level. So you have to fixate that. Now you can do, and I've done it this way in people that have really wide trunks, or somebody that has, you know, kind of a smaller hand that can't get wide enough to do that. You have to fix the opposite side rib and the opposite side of the spinous process. So in the position that, is that Jared that I'm seeing up there?
Back is Justin.
Justin.
You can call him Jared if you want, though.
That's fine. Whatever his name is. It starts with a J. So in this position, if Dave was going to wrap his right arm around to get onto Justin's left shoulder, he would have to block the right rib tubercle and the right side of the spinous process. So he'd go tubercle with the thumb and then index finger on the right side of the spinous process, and then he could pull across to produce.
You're gonna just check this way. Okay.
Yep. So he'd be pulling Justin's shoulders to the right in that situation. And then if he wants to push and go the other direction, he would just swap his hands. Now he'd get his index finger on the left rib tubercle and his thumb on the left side of the spinous process, and now he can push across. Or he could just swap sides and move sides.
Yeah, that's a more firm grip. I tend to be, my technique's been a little more lazy, where I can come in and after a while you get a feel for it, where you can just block the segment and grab both rib tubercles. My hand's big enough. I can come in here, and basically the shear is very subtle. Is there a give? What is that initial motion as you come here? Now it's easier for me in this position. Usually I'm back in here so I can take them right and left. But this is actually a better position. I have a firmer grip if I'm going to check it toward me. There's less noise. I think early on in this, that's part of it, is that it feels so much, we create a lot of noise. So this grip that you're using right over here for spinous process and rib tubercle is actually a good one, because there's less information to interpret with that unilateral check versus the bilateral.
Yeah, and with the squeeze, because you have to pinch pretty hard, it gets to be, you get to kind of lose some of that kinesthetic feel that you have on that fixating hand.
I'd agree.
Because you get kind of this, I'm working so hard to hold this together, versus if you can kind of just slide in from the side and fix the tubercle and then fix the spinous process, all you have to do is just kind of push away from yourself a little bit before you pull them toward you. That tends to be a lot easier on you as the therapist. The thing that I see the most being a problem in the courses that I've done, the thoracic courses that I've done. So if I have somebody come in and I have their shoulders here, so their back is facing you, and I'm trying to produce a right translation. If I get in here and I fixate this, as I see people, the two things that they do the most, that they have the most problem with, is they do this sort of thing, where they're doing it too quickly, or they just really crank too hard and they blow right past everything they're trying to get. So the key to this is fixate, get a feel for where this lower hand is. Really focus on what you're feeling through your fixating hand, and then it's a slow pressure through the shoulder girdle. Very slow pressure, because you have to essentially feel that you take up the slack in the mobility of the shoulder girdle, and then you have to work your way down the thoracic spine before you get to that fixated segment. So if I do this real quick, I'm blowing by everything. Or if I'm pulling too hard, then I'm not getting any real feel for what's going on. So it's fixate, focus on what feels here, and then slowly feel that pressure translate down to that segment that you're at, and appreciate how much give there is there. We will tend to feel one of two things. We will either tend to feel it be pretty normal, where there'll be a bit of give and you'll kind of end up with a capsular feel at the end as you start to run into the longitudinal ligaments and you start to run into the joint capsules and all the connective tissues that attaches to the ribs. So we're looking at the costotransverse ligaments and things of that nature, the radiate ligaments, etc. But the or we'll run into a hard block, right? So we're either going to run into this thing where it's subluxed or it's normal, if that makes sense. Because this is an intervertebral problem. We're not getting a lot of capsular lesions that are just going to affect these shears. These are pathological problems, right? These are something, and that's the other thing that you have to consider when you have these sort of transverse or anterior shear subluxations. Soon as you find one, you already know without doing any stress testing that this segment has some sort of instability to it. Because these are non-physiologic motions that shouldn't be allowed to occur in a stable segment. Does that make sense? So you know as soon as you find this, as soon as you correct it, that segment is now sloppy. It's going to be going all over the place, so you have to find a way to try and stabilize that. That is the biggest struggle pretty much of any orthopedic manual therapist on earth, is trying to find a way to stabilize a thoracic instability. Those things are the bane of my existence, and I'm sure most manual therapists' existence. Those things will tend to come back constantly. They drive you nuts. So yeah, I mean, finding ways to stabilize that stuff is difficult. You tend to, depending on where it is in the trunk, you tend to have to use the limbs. Try and position the thorax into a position where it wasn't able to get into. So for instance, if I have a loss of right latexion at say T4, this is a pretty common one. Actually, I tend to get this one from time to time. The position that I want to do my stability training in is I want to try and bias my trunk into that position and then use my limbs here with some torque to them, so out in front of me or out to the side of me somehow, and add some sort of load, whether that's a horizontal load or a vertical load. It doesn't matter. In fact, you probably want to do all of the above. You want to have load coming from above, where you almost pull down on a TheraBand that's anchored above your head. So I'd position myself here, and then I'd do some sort of slight pull down, something like that, or reverse it, step on the TheraBand and pull up, anchor it into a door, and just turn my shoulders like that. That's the best way you're going to be able to kind of recruit the musculature around that segment. It's hard to teach patients how to do that properly at home. You tend to see them in these positions and they're doing all kinds of crazy stuff and they're nowhere near the level that they're supposed to be working on. So again, it's a tough thing, but it's doable. The problem is that once it's gotten to that point where it started to sublux like that, odds are it's going to happen again at some point. This is the type of patient that you may see if you're doing a good job if they're doing a good job with their exercise routine and you're doing a good job with teaching them how to do it. You may see these patients a couple of times a year, just to get them back on track. And they'll tend to notice, as they're doing this stuff, they're just like, I feel weak. I'm starting to have neck pain, or if it's lower down, I'm starting to have lower back pain or something of that nature. Or they may have localized pain as it starts to kind of slip off on them. But usually they get to the point where they're just like, they call up and they say, hey, you know what? I think I'm a little jammed up. I need you to fix me up. Come in, you do the thing, and you take them through a few things in the gym just to get the muscles firing again. And then you say, okay, great. I'll see you in another 6 months, 3 months, whatever it ends up being. But once you start seeing these things, they're going to be there forever. There's no correcting this long term unless you're going to send them for like a prolotherapy or something of that nature, which has its own pitfalls from time to time. But that's probably the only way to structurally stabilize that stuff without surgery. And in most cases, you can manage this stuff.
I mean, there's something that you can play with. That gets in a Diane Lee's kind of material, just stacking it from the pelvis up, where you can look at, okay, you're coming up from the pelvic floor and the abdominal muscles into the thoracic spine. So when I retrain thoracic spine now, I really drive it from pelvic floor up, making sure, okay, can they get their, transverse abdominus to fire properly? Can I get the thoracic spine stacked, clearly on the pelvis and hips? And that'll be more of a module 7-8 thing. We're going to look at, okay, is my pelvis set and clear? Because if my pelvis is rotated, or my SI joint's unlocked, or I'm not firing the lower system appropriately, your thoracic spine will be off and shifted continuously. It won't always be subluxed or jammed, but you're going to have those corrections and those irritabilities and hypertonicities. So really in that thoracic spine retraining that Eric's talking about, the key component for me there is coming in from the bottom and saying, okay, can I get everything set from below and work up so that I have a stable base to operate on when I'm doing the bands? And I do exactly what Eric said. I do band resistance, multi-plane work. Can I stabilize? Can I stack my thoracic spine cleanly on my pelvis? And do I have any kind of rotations or shifts to find stability? So, though we always talk in terms of subluxations, we tend to get our mind fixated on that everything is stuck, but everything is not stuck. Most of the time it's shifting, as Eric talked about. It's in a transitional phase where it's hypermobile, it's moving too quickly. The muscular system isn't stabilizing that segment, or it's hyperstabilizing it with tonicity, which is where we started, is palpating for tonicity. But again, the flip side of that is when this segment is unstable and we're unable to kind of clear it, don't forget to look from above and retrain. I often think of where, the shortest part of my treatment is the manual therapy. And it takes me 40 minutes to do the motor retraining. So they do repetitive motor control exercises in any plane to retrain the system. So that's what's kind of cool about this, is that, we're teaching you essentially, if you do this well, the shortest part of your treatment. And the rest of it is, how do I then get them to stack, reload, correct, and get the nervous system to recontrol this thoracic segment or lumbar segment or hip or ankle that we're working with. So I'd like people not to lose sight of that.
Yeah, that's definitely true. And it unfortunately, and a lot of times when we're going through classwork, we don't spend enough time on how to kind of retrain these things, that the quote unquote rehab component. When we're looking at stuff like this and we're trying to deal with re-engaging some of that nervous system, some of that neuromuscular recruitment, the recruitment phase to me is actually pretty simple. The thing that you want to do is you want to try and increase the amount of time that the muscle is under contraction. So doing eccentric loading tends to increase the motor recruitment by about 30%. So if you're looking for a way to get a muscle to fire, to turn on, in order to try and retrain it, similarly with a quadricep after a knee surgery, doing eccentric loading is the best way to do that sort of stuff. It just turns on more of the muscle fibers. So I think I mentioned that during the class, but I don't remember what it was when we were talking about it. But that is a real thing, and you tend to have that sort of phase in your rehab programs for spinal stuff, where it's just, this is a recruitment thing. So the initial phase that I'll use is a reflexive recruitment. It's forcing the muscle to turn on based on a reflex arc. That's something that the central nervous system is going to mediate, and the instability is going to have a hard time blocking that out. So for me, like for instance, for the lumbar spine, the one thing that tends to be the most inhibited is the deep multifidi, right? So trying to engage that musculature, finding ways that it's reflexively recruited. The thing that I tend to think about, if I go out and I pick something up and I try and lift that thing up, if my multifidi, that posterior chain doesn't turn on, my trunk's going to tip over, right? So doing something repetitively here where we're just trying to do a little engagement, I will tend to have my patients either sit or stand or knee, half kneel, something along those lines in front of a table, right? Hook their arm underneath the table and then just press up toward the ceiling. That is going to reflexively recruit the multifidi. Similarly, if I go up on my toes and I'm trying to reach up overhead, same sort of thing. Those things early on, once you've started engaging treatment and you've started correcting the hypomobilities around it, engaging that musculature for a week to 10 days with stuff like that is paramount. You have to get the thing firing first. Then it's all about the amount of recruitment that you can get. Then we go into some eccentric loading, some longer durations, what we call tempo sets of exercises where you drag out the contraction and then you drag out the relaxation phases. That's going to increase the number of motor units going to fire. If you start to think about kind of the science behind that, the idea is when we're looking at, if you think about, for instance, when you have radiculopathy, radiculopathies are not testable unless you've already lost 80% of the motor units, right? In a typical muscle contraction, you get about 60% of the motor units turning on. So if you burn through that initial ATP that you have, which is about 6-7 seconds, then you've forced the body to transition into a second grouping of motor units. So that increases the number of motor units that is fired during that contraction, right? So if you do something where you have a 6-6 tempo, 6 up, 6 second up, 6 second down contraction, you know you've already engaged as many motor fibers as that muscle is capable of giving you. After that, it's all about building up whatever kind of strength the patient needs, right? So that phase will tend to last about 3 weeks, that kind of endurance phase, that kind of endurance recruitment phase. And then after that, it's all about building up whatever strength they need. So that's usually task dependent. If they're a runner, it has to be a ballistic task. So you kind of have to taper them into that. If they're a weightlifter, you have to start building up actual strength and power in the musculature. So it kind of depends on how that stuff goes, and you can tailor your things as far as that process goes based on what the patient is asking you for. If they say they want to go back to running, okay, we have to do some stability stuff with some dynamic tasks to it. If they're saying like, you know what, I just need to be able to lift my kid and carry groceries in from the car, like, okay, great. That's a sustained hold thing. So here, hold this weight, walk down to the other end of the clinic, walk back, do that about 10 times. You know, every time you, somebody catching on fire out there? Anyway, that's kind of the process that I use, because the recruitment stuff is, there's various phases to it that you have to think about. And I don't think we get into it enough during the classes. So if that makes sense, then hopefully that'll give you guys some ideas.
And we're happy to flush that out online a bit too, people discuss that more. And I'm kind of in line with Eric. It really is sometimes it's in line with the research too. So that it's usually somebody's not a strength issue, it's recruitment, again, inhibition, and it's muscular endurance. It's the endurance of these systems. And every exercise Eric gave had that endurance component to it. It's how do I build endurance in the deep multifidi and the stabilizing system? You know, so that way the larger muscle groups, your internal, external obliques can then fire off of it, if we're an abdominal example. But the transverse abdominus multifidi system needs to act as a stable base to allow that larger system to basically act. And we need muscle endurance for that.
Yeah. I think we're on the same page with it. It's just sometimes it's hard to get the carryover with the patients in order to get them to do it.
I think the task-driven idea is a very good concept. And it's one that we're going more to, and inherently I look at it as what do they want to do? If they're a runner, then it's run specific. You're right. If it's getting back to life, what are the particulars of life? Is squatting, sitting, putting out fires if that's what you do.
Yeah. So, what else do we got?
That could be somebody.
Questions?
I guess when we were kind of talking about like the lateral shifts and how that's going to affect tone and kind of compensations above and below the level of that lesion, I had a case that it made me think of kind of a very large barrel-chested guy. And since I'm afloat, I had never seen this guy before, but my colleague said, okay, well, maybe you can look at him because he's been really slowly improving. Like he had left about T9 left-sided thoracic pain, excuse me. And so he would keep getting these flare-ups but then he would keep getting better. It would just exacerbate kind of suddenly, usually when he was sleeping at night. And I did find kind of that lateral shift, but they had, like, if he was keeping to get better and better, it kept coming back. So I kind of looked below, kind of more at that TL junction, and I actually found he had a pretty significant hip subluxation, the UFR on that left side. So kind of activating that whole QL, because his tone all the way up that left side was really increased compared to the right side.
Yeah.
And I guess my question is almost like, okay, I know that these things are related, but I really flared him up that day. I fixed his hip and he felt better. He was like, wow, I feel a lot taller now on that side. I usually feel like I'm leaning over onto that side when I walk. And then he was like so aggravated the next time he came in, which then I found out later he actually just did a ton more that day because he felt so much better. But
it's 99% of the time, isn't it?
With this patient, is it his hip was always out, so he was creating this lateral subluxation above that had created, you know, chicken or the egg type of a thing. And when you're talking about you just have to stabilize it or it's going to keep happening, am I looking at I didn't get to the true etiology of that lateral subluxation, or have we not stabilized either, any, all of the above?
Well, here's the problem, is it can become a self-perpetuating issue at times. So if you think about the two kind of culprit things that you find a TL junction lesion, and then you find a hip lesion, right? Now and then you have a painful segment above that, right? You said like T9. So if you end up having a TL junction lesion, it can continue to throw off the hip, right? Via that psoas integration coming down into the lesser trochanter, and it can kind of pull that femoral head forward on you pretty consistently. And vice versa. If you have a hip lesion, it can affect stride length, essentially. So even just walking will tend to drive that dysfunctional leg kind of up into the trunk. And that can very easily, and it's probably one of the most common causes of these lateral shifts, is that leg length, that kind of functional leg length discrepancy. We'll get into that a lot more in module 900, whatever the advanced lower quadrant one is, about gait and how that affects things. So that could be it too, is the hip could be primary and it could be driving off the TL junction, or the TL junction could be primary and it's pulling off the hip. At this point, with somebody that's had this sort of stuff chronically, it's not going to matter, because now they're both keystone problems. The body has gotten into the habit of using that pattern, that profile of movement. So you have to find a way to break those habits, right? So looking at the hip in general, there's going to be consistent problems because that psoas tone is going to be so high. So you have to find ways to down ramp the psoas as part of the kind of quote unquote rehab component. Trying to use things like reciprocal inhibition for that is really good, because that focuses on the reflex arc. So working on hip extensor strength and endurance. So glute max on the ipsilateral side, and then even probably pelvic wall on the contralateral side. So we're talking piriformis and the posterior pelvic wall there. Trying to improve endurance out of them. That may mean some single leg stance work, maybe even some single leg stance with some trunk and pelvic rotation over the top of it. That stuff can help with down ramping that psoas tone. As far as the TL junction stuff goes, you need to work on kind of facilitating the thoracolumbar extensors. So trying to do that can be done in any number of ways. You're also going to want to facilitate some of the obliques. The external obliques are going to be very weak in those situations. So doing some sort of torsional trunk activity, or building off of an anti-rotational exercise like planks, like banded chest press. So you anchor the band off to the side and do some sort of banded chest press there. Destabilize them, put them in a stride stance and have them do those sort of things. Anything that's going to engage that as those obliques as a derotational muscle. And then you can also go back and then use them as a facilitator to rotation, which would be something like even just like a simple Russian twist, lean back and do this sort of thing. That tends to mean that you have pretty good control. Being able to do something like that, you have to be able to have pretty good control of the segment already. That's why you tend to go from make it a stabilizer and keep the trunk still, as opposed to trying to get it to produce movement. That's kind of the last step in that. But you have to be able to get them to do it because functionally we don't operate in these planes, right? We operate in diagonal planes. So you have to be able to retrain it at some point, but you have to have control of it first. The easy way to test for it, I think Jim has a video of it in module 1, where he will bias them into quadrants, and then he'll have them resist as he tries to pull them out of those quadrants.
I'll send it out.
Say that again?
I'll send it out in case you don't have it.
So I believe it's on module 1 somewhere, but it's just, you put them into a flexion, left side bending, and he resists as he pulls them out of that, and so you go into the 4 different quadrants there. They will remain weak in one of those quadrants if they still have some sort of inability to recruit around that segment. So once you get them to the point where you're actually looking at, oh, okay, they're strong in all 4 of these quadrants, sweet. Now I can challenge them with some of these actual rotational elements.
And so when you're saying that, you can almost certainly say that those obliques are going to be weak on that side. I guess we had kind of talked in the lumbar module about kind of that anterior sling, like your psoas is going to create that rotational moment, but wouldn't the obliques be completing that circle? So is it just that psoas recruitment and kind of hypertonicity is inhibiting the other part of that sling? Am I thinking about that correctly? Or I see that a lot, but I'm not sure why those obliques get inhibited.
Yeah, so what you're seeing is when we're dealing with a thoracic lesion, like TL junction lesion, or something even working its way all the way up to like T6, what you tend to get is, and Dave was talking about this coming from below as well through the pelvis, but you'll tend to see some of those long thoracic paraspinals, the semispinalis, and especially the iliocostalis will become hypertonic. Okay, and that's just because of the change of position of the rib cage or the change of position of the pelvis, right? Those things become very tight. That's what's inhibiting the obliques. Okay, because that's not part, the iliocostalis, et cetera, they're not part of the anterior sling. They're kind of its functional antagonist. And technically the psoas isn't part of the anterior sling either. It's more of a gate driver than anything. But the anterior sling is really the obliques and the rectus abdominis going down into and crossing across the pubis to get into the adductors. So adductor magnus, longus, gracilis, et cetera. Those sort of muscles. Those are the ones that you want to facilitate with an anterior sling method. So yeah, I mean, but again, if you're able to facilitate the abdominal recruitment, you don't have to compensate for it with the psoas. Okay, the psoas and the multifidus are essentially, they produce the same spinal movements, right? They will produce ipsilateral side bending, contralateral rotation, and extension. That's just what they do functionally based on their attachment points. So again, as the psoas starts to take over and pull so tight, it's inhibiting the multifidi because it's doing more than its share, right? You have to balance those two things out. But there's phases to that, right? Again, like we were saying, you have to kind of build up the reflexive recruitment so that damn thing's just firing when it's supposed to, then build up the endurance, and then based on the multifidus and where it's at, it has to fill in kind of this osteoligamentous tube between the thoracolumbar fascia and then the transverse process and spinous process. So it actually has to have a certain amount of bulk to it in order to put pressure on that and help create stability. So you actually do have to load that thing up with some, you have to kind of bulk it, essentially, if you want to think about it that way. Now, that doesn't necessarily mean having people doing deadlifts in your clinic. I mean, you could do that depending on how you want to go about it, but that has to happen, right? So in general, the psoas is kind of this catch-all. When there's spinal instability, especially from T12 down, it's going to tighten up, right? And it crosses the sacroiliac joint, it crosses the hip. So all of these levels of spinal mobility through the lumbar, through the SI joint, through the hip, if there's problems there, that psoas is going to be too tight. So finding out where we're running out of, where it's taking that from, whether that's part of the multifidus, whether it's the opposite pelvic wall, whether it's the ipsilateral hip extensors, you have to figure that out. And essentially it comes down to, you need to have articular mobility and muscular extensibility to allow full movement, right? Got to have full range movement, otherwise the muscles are going to be in disarray anyway. Once you have that, you have this window of opportunity to retrain the muscles that are insufficient, right? And so that's why we tend to do things with patients in the clinic. You can teach them what they need to do at home all they want. You can, give them day-by-day exercise routines, which I've done in the past, and send them home, and they're still going to lag behind because they have to have that mobility first. So we fix them up, we get them moving, and then we teach them these things that they can kind of do in order to help increase that recruitment. It's a process, because you have to get through those kind of 3 phases. Once you get through those first 2 phases, you should be in pretty good control. And then that kind of 3rd phase of rehab stuff, of the exercise component, you can kind of tailor it to their needs, and you can be a bit more aggressive, and you don't need to see them quite as often, because hopefully their mobility is holding up better outside of the clinic. Yeah. I always tend to tell patients, you're going to need to see me more consistently early on. And then we're going to try and slowly ramp you down on how often you have to come in and see me, and build up the stuff that you can do on your own, because that's what you want to essentially do. You want to get them down that curve to the point where they're self-managing, right? They don't have to come and see you. But yeah, I think from a perspective of how do you do that, it's the same stuff we've just been talking about. Get them moving better. So joint stuff, make sure the tissue extensibility is there. Make sure the motor tone is where it needs to be, so you're not dealing with a lack of movement due to hypertonicity. And then you start rehabbing the muscles that became insufficient in that process. And so that, like I said, with the psoas stuff, there's going to be a bunch of different targets here. And again, you can kind of figure out where it is based on the patient's complaint and what their activity is that they're having a hard time with. If it's, just carrying stuff in from the garage, it's probably a gait problem. A loading and gait problem. If it's somebody that's an athlete and they're a runner or they're a soccer player or something, it's probably a ballistic thing, which would be more kind of that speed dependent stuff that we've sort of broached on very briefly. But when you have that sort of stuff, you just have to figure it out and kind of tailor your routine from that. Does that answer your question? Yeah. I know I got rambling a little bit there, but. Okay.
Katie, I'm going to go back to Katie on kind of what you talked about, where what you did was absolutely correct. And what Eric said, I think, is a camera in our clinic, because we do essentially what Eric said. So it's kind of weird he's watching us all the time, but I don't know, kind of nice too. But you corrected the hip. And if you think about it, we have a hip stuck forward, and let's say the pelvis goes along with the hip. So if I have, it was the left hip you had said, Katie? Okay, so if my left hip, let's say it sits slightly anterior, if it pulls my pelvis slightly anterior, it's going to cause a transverse plane rotation of my pelvis to the right, this way, okay? So what's my thoracic spine going to do? It's going to self-correct this way. Now, depending where I maybe restricted my thoracic spine or along the pathway, I could have a couple corrections. So you get the hip, the pelvis is rotated this way. You get that hip, and that pelvis is able to reseat better. Well, now my thoracic spine's had this correction. So as my thoracic spine, now if I still have my thoracic spine correction in place, now his thoracic spine is trying to counter torque back out of it. So what you see is very typical. He came back like, oh, I'm doing better here, but oh man, I got this other pain above it. You found another level he had in his thoracic spine, which was probably correcting for it and bound in the opposite direction, which wasn't readily apparent because you weren't looking up that high or you didn't pick that correction out. Here's what you do early on. There's other ways to go up in there and identify these segments and find them and correct them. But what I prefer sometimes when I'm lazy is the shotgun approach. Do you remember how to assess the ribs in prone for anterior medial, posterior lateral glide? That's a rib mobilization when it comes down to it. You can come in there after you make one of these big hip corrections and you think, man, he's going to have some counter rotation, which I may or may not find. Go in there, mobilize the ribs and the upper thoracic segments. And what you're doing is kind of a cleanup technique. That rib and that segment may not be stuck or subluxed. It may just be myofascially toned in that direction. And then you wind it up. So it may not be stuck. You go there and poke on it.
Facilitated from its compensatory strategy, essentially. So you're just kind of cleaning out.
Yeah.
its information, basically.
You want to relax the ribs, do the rib glides. You find one that's restricted, manipulate it. But if you're like, man, I'm not quite sure what I'm seeing here, but I know I just made a big correction. I know he had a transverse plane rotation in the pelvis, which I probably largely influenced. It's going to correct in the thoracic spine. So you hit the primary driver, and he's got a secondary driver in the thoracic spine, which could be the correction or part of it. And that's what you ran into, which is very common. So when that happens to you, part of you is like, awesome, I got it. And part of you is like, shit, I forgot to tell him this might happen. Okay? And so sometimes I warn people like, hey, listen, I'm going to correct this, and you might see this in your upper spine. If it is, just give me a holler, come in. I'm going to correct it real quick, and you're going to be on your way. But early on in this phase right now, the carpet approach is let me get in there as to hedge my bet. Let me clean up any compensatory myofascial tone, rotation with proprioceptive input. Proprioceptive input to the joint is going to down ramp tone. It's going to block pain. It's going to block pain at the segmental level, basically through gating there. It can block pain through the suprasegmental level, through the midbrain and periaqueductal gray matter has descending inhibition. So if you go mobilize these ribs, you will down ramp tone through several mechanisms. If you stick a needle in it, lo and behold, that pain modulating pathway and picture looks pretty similar to the mobilization one in the neurophysiological impact of pain. So you can needle some of these segments that are paraspinal in that region. And I may use more of a carpet bombing approach than a local approach if I were to needle. To say, okay, what am I missing? I don't quite see it. Maybe it's 5 o'clock on a Friday and it's just not in my system. I can do a more general approach now. And then as you get better at this, you're going to go there, well, I'm going to go look for the other segment now, which is off. Because I fixed the hip. I got the TL junction. There's something above it correcting. And what Eric said is probably right. What do you say, Eric? Between 4 and 6?
Yeah.
You know, so that may be where I go. If I don't find something between 4 and 6, don't beat yourself up. Just look elsewhere. It's just a first go-to. But the reaction you got was awesome. You got exactly what you wanted. You created it. You know, and you may find that, and I wrote up notes, and I will send out my notes. If we didn't have good questions, which we had awesome questions, I wrote up notes to cover some of the slides that were in the presentation today, and I reordered them. I will send out my reordered slides, and you know, hopefully Eric can do this again next week, or in the future maybe we'll trade off.
I'll have time, yeah.
And we can go over it again, and we'll go over the slides of Gail. I reordered them a bit to looking at flexion and extension of the lumbar spine, and because those H's and I tests, but you know, I'm a little biased that I don't use H and I tests much because, quite honestly, it means by the time I have the H and the I, it's like, okay, I don't know what the hell I'm doing, so why am I doing this? I usually do it just to see, do I see it match what I saw otherwise? But we'll look at those, and what we want to look at is when we look at pelvic flexion and extension, or flexion extension, what's the hip doing? What's the pelvis doing? What's the lumbar spine doing? What's the thoracic spine doing? And then once we kind of get a sense of what all these segments are doing and where do we have a segment that may not be moving appropriately, that may be our closer driver. So what we're going to do next time is kind of take a look at that. And then we can kind of, I pulled out the slides that were slides 20 and what you have in the neutral zone. We got a little bit into the neutral zone today, but I think we covered that as well. Because that really comes back to what we're talking about even here, Katie, is that you fixed a jam segment where, okay, maybe they're hypermobile in the hip, we have an unstable hip, and now you've corrected the position. But now we have that upper segment, which is more of a myofascial restriction up at T6, which then kind of drove his pain again above it. Does that make sense? So don't beat yourself up if you don't get the concepts or fully feel it. Just know that, okay, I can go in here and proprioceptively do some cleanup work using the biomechanics of the joints. And I probably use the biomechanical application of these techniques at a scale of 3 to 1 to manipulation. Otherwise, I'm applying these biomechanics when I evaluate movement, when I treat, when I look to correct dysfunction, way more than I manipulate. And I manipulate a lot, but it's not the basis of that's all I do. Is I do the motor correction Eric does. I look at biomechanically, do I see this person transferring load appropriately, or do I have a failed segment? And that's kind of what I think it's what Chris Gray's seeing in his ballerina that he put up. And I think Matt commented on it too. It's that failed load transfer you guys are picking up on. I'm going to read questions. Eric, you have anything on that?
I tend to agree with pretty much everything you're saying there. I mean, I like the idea of going in and being able to just make sure that they're feeling well on the way out. So that kind of down ramping stuff. I mean, that's kind of where needling comes into play for me. Is I don't use it a ton, but it's a good way if somebody's having that sort of tone issue and you just need to get it out of the way so it's not affecting their biomechanics. And that's a fine way to do that stuff. And certainly I think the stuff that Dave's talking about there is a good way to do it. Gail goes into this stuff, and I know Rich Monaco got real into some of the like spinal harmonics and some of those sort of things. And I don't use it all that often. So
I don't do that.
I don't teach it just because I don't know it as well as they do. But it's basically just these kind of subtle rhythmic movements. And the whole idea is just to down ramp tone, just to get that kind of pathological tone out of the system. I tend to think if you're using it for that, you can kind of do that stuff anywhere in the body. Like you wouldn't even have to necessarily be in the region. Like if it's a thoracic problem, you could probably do it to the cervical spine and get a gross motor decrease on that sort of stuff. Again, that's why they say that needling is effective, that there's this kind of systemic decrease in muscle tone. So in theory, this is why acupuncture is effective, because somebody goes in and jabs a needle into my foot and suddenly my levator tone goes down. They're like, oh, it's a meridian point. Like, no, it's not. It's a systemic reaction. So that's why that stuff happens. But I mean, people tend to get kind of fixated on that quick fix. They're just like, well, it was great. And you just keep doing that for me. Like, what, you want me to do that to you 3 days a week, twice a week, every week for the rest of your life? Like, sure, it's good for business, but it's not fixing you. And eventually the insurance company is going to say they're not going to pay for it. So, yeah, I think all that's pretty good stuff, though. I mean, I'm kind of looking through some of the group chat stuff here, but yeah, I mean, I think Dave's right on with all that.
All right, Chris Gray, you want to explain how you use the H&I test? Chris?
Yeah, sorry, I had to unmute you. Are you there?
Yes.
Yeah, basically what I was the HI test, we're looking for instability. The patient in question, when I would bring her back into extension first and then take her into left side bending, she had good mobility, no discomfort. When we would take her into left side bending and then trying to come into extension, she was blocked and had pain. The way I've always understood that was that would indicate possibly she's going off the rails. She has a lateral clinical instability, not a surgical instability, but a clinical instability, to where when she goes into left side bending, she goes off the rails and can't go into extension now.
Yeah, and I think how that's beneficial to you is it gives you the plane of motion that she's going to have problems in. So that lateral movement is going to be a problem for her. So being able to try and tailor some of your rehab components to that, I think, can be very beneficial, because otherwise, and I hate this. I hate when therapists do this, but they have these umbrella treatments. It's just like, oh, you have a lumbar problem. Here's our lumbar training protocol. Here's 6 weeks worth of exercises, and all it is here's this thing, and they're just hoping that they fall underneath that, and that's going to help them get better. If you can be specific and you can say, oh no, they lock up when they go to the right side and then try and go back, that right side bending motion is going to be probably unstable, especially because they can get there by going a different direction. So that can help you. That's useful information when you're trying to get in rehab some people. So.
And for her specifically, what I found was she had an issue with left side bending and then right rotation. And so when we treated the TL junction to get back that right rotation, she had better left side bending into extension, which for her was important. I'm starting to get more professional dancers just in the location I'm at, where I'm going to butcher the name, an arabesque maneuver, where she was standing on her right leg and going into an extension position. Anyways, that's...
So if you corrected the TL junction and it improved the symptoms of that segment, do you have the finding you said you had?
Dave, can you repeat that one more time, please?
Okay, so if I correct the TL junction and the thoracic mobility, And then in actuality, do you have the lumbar lateral instability that you talked about?
I do think she has a clinical instability, or she has hypermobility at that area, because even after we corrected it, and it did improve her asterisk sign, let's say 50%, it still was there. And then when she would come back, she regressed. And I noticed that if I didn't work on her right hip along with her TL junction, we didn't get as good a result. I had to treat above and below that L4-5 issue she had on that left side.
Yeah, so
am I making sense?
You have pain at that location, a driver. That's what I told you with the HI test. I'll send out my notes, which I had originally for today, so we can cover them for next week. And that's what we looked at with flexion, extension, and different movements is exactly this. It's looking above and below that lesion to clear it up. Like when I extend back, what's my hip doing? When I go to lean back, how fast does my hip move? Does my hip move at the right time, or does it move late? So now I hinge through my lumbar spine. It's all about force transfer and load transfer of this individual. She's having problems with some load transfer, and that's what you're seeing. So yeah, you're right. She gets complicated because of being a dancer, but you're right. You have to clean up the mobility at segments and also get her neural control better. At some point, there's a moment where she's loading through that L5S1 segment, where either from her hip, her foot, her thoracic spine, there needs to be a better moving segment around there to deload it. And that's why that segment's becoming unstable and overloading. I'll see in lacrosse players, usually teenagers, they'll do a very similar mechanic, and it'll load it. It looks like a pars fracture, but it many times isn't, but it can lead to it. That's the way they load that segment. So they do have the clinical instability, but the next part of what I want to look at going into this in module 5 is that, let's look at these patterns a little bit closer and figure out what are all the things now that in our arsenal we have that we can assess with a simple flexion and extension and a side bending. We start to evaluate hip, spinal motion, and kind of sort of think about these interrelationships.
Did you say you have some notes on this specifically?
Yeah, I'll send them out. I'm redoing the module 5 manual that everyone has in there. And Chris, I'll put you in their module in Chicago so you can see it.
Okay.
And I'll send out the notes as I update them. I sent them to Eric just a few minutes before here. And that's what I was thinking about as we do this, is to go through that manual, and it's basically what's going to amount to be a 3 to 4 month stretch for the Chicago individuals. But I'm also writing it at a level for the fellowship, so that part of the discussion will be at a bit of a higher level as we go through this. And going over these patients is fantastic. It's exactly what I want to do. It's way more interesting than talking.
True. All right, guys, I got to hit the road.
Yeah.
So good talking to y'all.
Okay.
And I should be available next week. If you guys pick out a time, let me know. There's only a few times during the week that I
we'll try and keep this time for people, unless we get a large demand for something else.
Yeah, that'd probably work out.
Okay.
Hey, thanks guys so much. Really appreciate this.
No problem. Yeah, I hope this was helpful for everyone. And feel free to send questions over that period of time between now and next week.
Will do.
Sounds like
Thank you.
No problem. I'll send out I'll put the recording up online.
Okay. Thank you.
All right. Take care.